what is the efficacy that one could expect with renal denervation as being done?
Sure. So to begin with, over short-term follow-up, the efficacy we see with regard to a blood pressure reduction is analogous to that relative to a single antihypertensive therapy, roughly 10 millimeters mercury reduction in office systolic blood pressure at early time periods of 3 to 6 months. However, as we've recently published and presented for 3-year follow-up in the context of medications and similar medication burden to the sham control group, through 3 years, we see reductions from baseline to about 20 millimeters mercury. So we see a continued divergence, an escalation or a divergence, an exaggeration of the benefit over even longer term follow-up. And to supporting on the clinical and the preclinical evidence, to Andrew's point, we don't see a regression or suggestion of reinnervation, which has been suggested by some.
Thank you very much, David. Flavio, maybe I could bring you in. We have a question from the audience that's really kind of pertaining to your talk, that you're about to talk to us about the real-world experience. And the question that we have from Lal Mughal from home is saying, what's the learning curve really for this technique? How many cases do people need to do to master it and be able to do it on their own and become an independent operator? And where do you see the focus being? Will this be a widespread procedure in lots of centres, or will it be in more specialist hands that people really acquire the knowledge?
Well, it's a very important question. It's not easy to answer because, of course, that depends on the experience of each operator. If you are an experienced operator on performing, for instance, renal artery stenting, then the procedure is very, very easy. If you have never catheterized a renal artery before, then you need some training. The advice would be to observe at least 4 or 5 procedures and then to work with an expert for another 4 or 5 procedures. These 4 or 5 is a number I've just invented in this moment. I mean, it's not written anywhere. But this will help you to understand, to start with a non-selective angiogram with a pigtail, because sometimes the arteries are not where you expect. And if you try to engage it selectively because you are good and it's easy, you will spend a lot of time and you will get a lot of contrast, and contrast is a poison for the kidneys. So non-selective pigtail, then you see where there are the arteries, you will see which kind of catheter will give you the best support. Then the technique for a cardiologist is simple. It's a wire, it's a coronary wire, it's pushing a catheter with a very good deliverability, and it takes time to irrigate the energy. It takes at least 1 minute for each ablation delivery. Then what to say? I mean, it's all based on the experience.
Where do you see it going in terms of centres? Do you think there's going to be a rollout to lots of centres, or will this be in specialist hands only?
I think that as the treatment is concerned, the therapy is very simple, can be performed by any interventionalist after adequate treatment. I think what is necessary is to centralize the patient in a dedicated center that has all what is needed to get the patient referred, to rule out all the secondary causes of hypertension, to take care of eventual complications, which are really very, very infrequent. Most of them as just minor complications at the access site on the groin. Of course, to check for the renal function, because you give contrast, you get into the artery. Normally, all these arteries are normal, so there are not risk of embolization, of dissections and all that. So the important is to centralize the treatment in dedicated centers. But for the operators, I think that there is no need to have very, very high volume centers to do that.
Thank you very much. And now I think it's probably time to move on to our next talk. So Flavio, if we could ask you to come to the lectern, and I think you're going to speak really to this point of navigating the procedure, the kind of real world experience that you've had from your wealth of experience.
Yes, thank you. This talk is totally linked to the previous one. We are, almost all of us, we are interventionalists, and we have lived all the development of devices. And until a few years, we wouldn't implant a drug-eluting stent without knowing the animal results. And we had Reno Virmani showing us what was the endothelialization and the late reactions of the polymers and all that. Renal denervation needed this information, and what Andrew Sharp has shown is absolutely reassuring, because there is clear evidence in the animals, and these are more than 150 pigs, I guess, so it's a very large anatomic and histologic examination, that what we are going to see now in terms of clinical results is supported by clear evidence of animal efficacy and safety. So I will start with a proof of concept. So we want to know whether radiofrequency renal artery ablation thus produce lower pressure. So this has been tested in a model of study that has been developed after the hypertension 3, after the mistakes that Andrew alluded before, which is the proof of concept of efficacy. So are patients naive of drugs? So these are patients with hypertension, but not taking drugs. And these are the results. I mean, the results are published, you know them very well, but one of the most important differences in between this device-based therapy and the drugs is the effect on blood pressure lowering is totally independent of pharmacodynamics or pharmacokinetics. So what you see is a reduction of the blood pressure that lasted 24 hours a day. Independently, if you are eating, you are sleeping, you get angry, you are running, or whatever. And this is very important because we know that most of the clinical events related to hypertension happened early in the morning, while you are sleeping and waking up, and when the drugs have this problem of gap in the dosage and the pharmacokinetics. Second is the demonstration that the medications add effect on top of medical therapy. This is the second clinical research model, which is called on-med trial, and these are patients with worst hypertension, higher hypertension values, that have been randomized to continue the drug therapy, plus a sham procedure. So these people went home convinced that they got the procedure, they got the puncture in the groin, they stayed in the hospital, compared to those who continued the medical therapy plus the renal denervation. And again, look at the difference. On the left side, you have the pressure blood drops, systolic and diastolic, in the patients without medicines. It's 5 to 9 millimeters of mercury compared the 24 hours on the office measurements. And on the right, you have the pressure drop after medical therapy in patients that were taking at least 3 drugs. So that you see that the effect is consistent regardless of the fact that you are taking or you are not taking the pills. But what is even more important, and it's strongly supported by the animal data that Andrew showed, is that if you had a concern of re-innervation, rebound effect, loss of efficacy, this has been shown a month ago, published on Lancet, the 3 years follow-up of this on-med therapy follow-up. And you see that it's not only preserved, the effect is incremental. The blood pressure drop at 3 years, it's in a mean of 18 to 20 millimeters of mercury systolic and 6 to 12 diastolic. So there is no rebound, the effect is there, and it's getting bigger as time passes. And the consequence of that is, as you can see, the number of medications that patients were taking, 10.3, compared to those who underwent the renal denervation at 3 years is 7.6. So a long time, these patients kept on having their drugs, because this is an important concept. Renal denervation will not free you of any drug, will help you to keep your blood pressure on target, but with less drugs. So the drug burden, the fact that you have to remember taking the pills, you forget, you don't like, you have collateral effects, and this creates what we call non-adherence of the patients, is much lower because you need less pills, and this is significant. So the always effect of the renal denervation is maintained at 3 years, and this is another very good news. Indeed, you see that patients having a blood pressure, systolic blood pressure below 140 is over 80% among those having pills plus renal denervation, and is just a little bit more than 40% in those who did not undergo the procedure. So this shows clearly the additional effect of renal denervation. And last, when we talk to real life experience, we have this important data that derived from the Global Simplicity Registry. This is a huge registry performed with radiofrequency renal denervation that has been including patients since already more than 5 or 6 years in worldwide. So you see that there are more than 3,000 patients that have been treated, with many of them having already 3 years follow-up. So in terms of efficacy and safety at long term, this is very important data. These are not patients selected for a randomized trial. These are patients included in a registry because of resistant hypertension. And as you can see, again, the efficacy of the treatment gets more and more important a long time, from minus 13 millimeters of mercury 6 months after the therapy to 16 when you measure the blood pressure in your office, or from minus 7 to minus 9 when you do the ambulatory blood pressure. This has been demonstrated in all subgroups, patients with AFib, with diabetes, with CKD. And again, the reduction of the drugs a long time is significant in these patients. There is still a 20% of patients that, despite the drugs and despite the renal denervation, are not yet on target, and their blood pressure systolic is higher than 160. But this represents nearly 20 to 25% of patients. Last, it's an experience performed in my center. Why is that important? Not because I want to show you what we publish a paper, but just to show you that all what have been shown before has been sponsored by the company. What you see in this paper has been performed in my center with the radio frequency device. The Medtronic has nothing to do with this data. It's our experience with very, very critical patients. These are not patients. I always say we don't treat in Verona patients who are hypertensive. We treat patients with hypertension, but have heart failure, acute MI, AFib, diabetes, COPD, peripheral arterial disease. And in this population of patients with CKD, in most of them, you see that the mean GFR was 47%, but we have patients in dialysis also in this series. The blood pressure drop is identical to that I have shown you in the studies, either in the randomized or in the registry. It's about minus 7 systolic after 3 months. There is an incremental effect at 6 months and even more at 12 months. And which is very important of this series that has many patients with severe GFR impairment is that there is absolutely no change in the creatinine values after 1 year. To end up, this is the final slide. Andrew have shown you that the preclinical studies have confirmed that there is a reduction on the norepinephrine release in patients treated compared to control. The randomized trials have shown that there is a significant drop of blood pressure on top of medicine, and this is persistent after 3 years. And the registry have shown that this effect is observed a long time and in different subgroups of patients. Thank you.
Thank you very much, Flavio. Are there any questions from the audience? There is one, yeah? Please go to the microphone because of the audience that is connected online.
Thank you so much for this excellent presentation. I'm Dea Hakim from Brigham and Women's Hospital in Boston. Just have a question. I think we know that for hypertension, the lower the better. But do you think that lowering blood pressure can be translated after to more clinical outcome points like mortality or left ventricular
Very good
dysfunction or
question.
something?
Mm-hmm. The patients we have been treated are really severely hypertensive. And even with the therapy, the best what we can get is to put them on target, which means systolic below 140, diastolic below 90. I can tell you we had only one case out of nearly 90 with a very young lady who came with an almost non-human therapy in terms of amount of drugs and doses of drugs, and she needed to be sent to the hospital to intensive care unit because of a hypotensive crisis. But the drug therapy had not been changed, and after 3 months and a half, she really fell down because of these drugs. Now she is taking a normal therapy, 1 beta blocker, 1 ACE inhibitors, 1 diuretic, and she has absolutely normal blood pressure. So I think it's important to set the therapy. This is not the first thing to do. After you treat the patient, you should wait until you see the effect, because if you take the pills immediately afterwards, you will see that the pressure goes up, and then you don't believe on the therapy. And so it's very important to follow up these patients. As far as we know, at 3 years, I am not aware about side effects related to low blood pressure.
Yep. But also, with respect to the question, Andrew, and I think the colleague is absolutely right in asking whether this should translate into improved outcomes, because this is lacking, right? We have not shown that denervation reduces the risk of myocardial infarction, stroke, hospitalization for heart failure. But we can use historical controls, right? And let's assume we'll document a 10 millimeter reduction in office systolic blood pressure. What would you expect to see in terms of relative risk reduction for heart cardiovascular outcomes?
Well, there's a meta-analysis in the Lancet by Lewington looking at mechanisms of blood pressure control that would reduce office blood pressure by 10 points. And what it showed is a reduction in MACE of 20%, a reduction in all-cause mortality of 16%, reduction in stroke of 27%, heart failure by 28% for a 10 millimeter reduction. And it appears that we get that if we do it with salt reduction, weight reduction, all the different drugs. So I guess the question is there a mechanism by which renal denervations, blood pressure lowering, would escape that? And the answer seems it's unlikely. I actually think it might be the other way around, because you're getting the therapy every day, whereas in the clinical trials, they may not have been taking their pills every day, and weight fluctuates. So I think it may be more bang for the buck in terms of outcome reduction. In terms of how to do an outcomes trial, it's really difficult. If you look at a trial of a single therapy back in the 80s, you might have had a atenolol versus placebo. The pressure in the control arm in that group was 165 systolic, and they were left at that for 5 years. And they had really high stroke and heart attack rates. That's why we treat blood pressure, because we found out in these trials that you must treat blood pressure. So what's our control arm for an outcome study for denervation? If we do it in mild hypertension, the trial will probably cost over $1 billion and will take years and years and years to recruit to. And we'll probably already have an answer by then from the real world. I think there's no reason to suspect it won't do what weight loss exercise, salt reduction, alcohol reduction, amlodipine, candesartan, and so on do. And the FDA agrees, of course, because new antihypertensive drugs don't have to have outcomes data anymore. They just have to show comparative effectiveness.
Yeah.
Thank you very much for that, Andrew. Flavio, if I could bring you in again, we've got 2 questions actually from the audience again, related questions on that renal question and what we should consider in terms of renal function. So the first is, what happens to renal function in the long term after RDN? And the second follow-up question is, can we consider this in patients on hemodialysis?
Okay, very, very nice points. So if the patient has already an impaired GFR, because he has diabetes, he has chronic kidney disease, which normally is secondary to hypertension, what we have learned is that with a cautious procedure, you can do the procedure with less than 60 and 70 milliliters of contrast media. This is harmless. You hydrate your patient before the procedure, you continuous hydration, like just with any other contrast-based procedure. And in this case, you don't have contrast-induced acute nephropathy. And what our nephrologists say is that due to the better control of blood pressure, you will preserve nephrons at the long term. So there is a natural history of the chronic kidney disease based on the diabetes, the hypertension, whatever this is, that makes the renal function impair a long time. But the most important stressor for the kidney is high blood pressure. If you control blood pressure better, despite this little bit of contrast that you have given to the patient, the renal function will get better at the long term. And this is a very, very interesting point that we are studying together with our nephrologist, and it's a fascinating point. Because you expect, nephrologists know exactly which is the drop of the GFR per year in these patients. And what they see is that this drop is reduced and for years is maintained. Then in the end, of course, the disease will progress. But the better the blood pressure control, the longer the benefit on the kidneys. And the other question related to dialysis, it's dialysis, of course, it's a more difficult setting. The vessels are smaller, but what is an incredible help for these patients is to avoid hypertensive peaks that normally create pulmonary edema and acute need for hospitalization. This is the most impressive effect that we have observed in these patients. And then you have young patients in waiting list for transplantation that cannot be transplanted because of very high levels of hypertension. These patients improve their blood pressure control and can undergo kidney transplantation. This is our experience. So it is effective.
That's fantastic. And I think we've just got one follow-up question, if that's okay, just on the same point. Can we consider this in patients who have a single remaining kidney?
Yeah, we have published this example also. We had a patient with a previous nephrectomy because of a malignancy, and he developed very high blood pressure, and we treat one kidney, which was a normal kidney, and we got effect. There are two cases as far as I know. You may know better than me, but
But it's probably not the right patient population to start with, right? Neither those patients on dialysis nor those with an EGFR below 30 ml per minute, or patients with a single functioning kidneys. They have been excluded from the randomized sham-controlled studies, and you need to be well trained, you need to have experience with the procedure to do that safely, also in patients with very low EGFR values. Would you agree?
Yeah, absolutely.